Good evening, everyone. I feel very short behind here. Very nice to be here tonight. Thank you very much, Bill, for inviting me. And I haven't been primarily treating PTSD for quite a while now, but I spent maybe 6 or 7 years just treating PTSD. I started off working when I first finished my residency. I don't know if you know Dr. Malavi, but he lives here now. He was my sort of mentor at the end of my psychiatry residency, and I treated schizophrenia. And then I started working with CFB Halifax as a civilian in the Canadian Forces Base in a post-traumatic stress disorder clinic. And then I was recruited to British Columbia and Dr. Gannison to work in a PTSD clinic. And there I worked for the Vancouver Association of Survivors of Torture. So I've had quite a range of experience with different kinds of trauma. And now PTSD permeates, I think, every psychiatric practice. So I have a general practice. I see a lot of bipolar disorder, depression, schizoaffective disorder, lots of anxiety disorders. And so PTSD is a part of that. So what I'm going to try to present to you tonight is a very clinical talk. If you have a burning question, I really truly don't mind stopping and answering your question. I'm going to try to keep this quite tight because we're a little bit behind, and that way we have a few minutes for questions as we go through as well. So I'm not really talking much about drugs, which is what I spend a lot of time doing, because my goal in life is for family practice. Well, I have many, but this particular one in my professional world is for family practitioners to be rational, confident prescribers. Because I think that you do most of the psychiatry in this country, and we have a lot of ill patients that require both psychotherapy, a biopsychosocial approach, but you guys got the prescription pads. So I spent a lot of time speaking about rational pharmacology. Tonight I'm really going to talk mostly about the phenomenology of post-traumatic stress disorder. So the DSM-4, and really unchanged in the DSM-5, we have this key A1 criteria for post-traumatic stress disorder. You have to have experienced, witnessed, or been confronted with an event or events, actual or threatened death or serious injury, and that your response to that is intense fear, helplessness, or horror. That really has not changed in the DSM-5, but a couple things have changed that I think are important and quite valuable. It actually allows, for the first time, the experience of first responders. And that wasn't really included in the PTSD criteria until now. It does not include exposure over TV, internet, except in some situations. The negative alterations of cognition and mood associated with a traumatic event are actually included in the criteria. There's also dissociative symptoms specifier, and I'll talk a little bit about dissociative experience. And there also includes PTSD criteria for kids who are under 6. So there are some important changes here, but I think particularly talking about people being exposed to someone else's trauma, particularly in the context of being a first responder, is a major change. They also have acute stress or acute stress disorder, and really this is exactly the same as PTSD, but it has to do with when it occurs. Duration of 3 days to a month after the trauma. So by nature, people talk about complex PTSD or chronic PTSD, but really all PTSD is pretty well chronic. You can have an acute stress reaction, but once you start to develop these symptoms after the first couple of months, they tend to be really in the chronic realm. Most of the population, most of us at some time in our life will experience a traumatic event that meets the A1 criteria for post-traumatic stress disorder. When you think about the likelihood that you're going to be exposed to a trauma, men are actually more likely to be exposed to a traumatic event, maybe because men aren't quite as careful as women or some take more risks, but women are about twice as likely to develop PTSD. And when you think about the anxiety disorders in general, that's the case. Women are more likely to develop depression and anxiety disorders, usually in the 2-to-1 area, and the same thing with PTSD. So while men are slightly more likely to be exposed to trauma, women are still much more likely to develop PTSD. While most people are exposed to traumatic events sometime in their life, what's the most likely outcome? The most likely outcome is recovery. Most people who are exposed to trauma do not become ill. This is Breslau. This was older data, but in one large study, he found that 90% of individuals have been exposed to a trauma that meets that criteria. So while PTSD is the thing that we tend to think about when someone's exposed to a traumatic event, it's actually not the most common thing that happens after a traumatic event. If you're going to develop a mental health problem, it's not the most likely that you're going to develop PTSD. People can develop just generalized anxiety, depression, substance abuse. So there's a range of mental health issues that can be provoked by exposure to trauma. We do know that the type of trauma is important, and sexual assault probably carries the highest risk of post-traumatic stress disorder, and I'll explain a little bit more about why that is. So I want to tell you about a patient of mine, and I still have her as a patient, but this is some time ago when I met her now, maybe about 10 years ago. And then at that time, I met her actually through the Vancouver Association of Survivors of Torture. So she was 22 at the time, and she had 2 young children. Note the age of the children. So she was a very young mother. She was a refugee from Iran where her husband had been jailed and he had been tortured in jail. He was a student protester. What happened was she didn't know where he was taken off the street. She was going to the courthouse again and again, and finally she got the ear of someone, begged him, was going to pay him off. Her family had some money to get her husband out, and the judge said, yes, I will get your husband out, but I have to take you to the prison. And unfortunately, when she got into his car, immediately she realized they were not going to the prison. He took her to a place, he sexually assaulted her. Then she was threatened that she would, if she told anyone about what happened, that not only would her husband be killed and never get out of jail, but also continue to be there, but also that she would possibly die. And she was absolutely terrified by her husband's response. So these are the kind of experiences that she told me about. I remember PTSD, there are 3 main clusters of symptoms. So she certainly had hyperarousal symptoms. And most people, if you sleep and you have PTSD, I don't know that you have PTSD. I've never met a patient with chronic PTSD that had great sleep pattern. She was irritable, very quick to get frustrated with her children. Her children were always walking on eggshells. She was extremely irritable, quick to snap. She said she was never safe. I can't be alone. And she generalized that fear to all men. So now all men became dangerous. She also had a number of avoidance and numbing symptoms. She felt that her life was over, that the only part of her life that was positive was her children, and she had some hope that they would have a good life, but her life was done. So a sense of her future being shortened or lost. She only experienced a negative valence of emotion, so she couldn't ever say, I felt happy or joyful about anything. I feel no happiness, only pain. I never stop moving. If I leave what I'm doing, if my brain disconnects and goes off for a moment, I'm back and around immediately. And she therefore avoided all men, particularly Persian men, and she had come to Vancouver as a refugee, and there's a very large Persian population in North Vancouver, and of course that's where she was settled. So she was surrounded by people that she found really quite terrifying, and nobody knew what was going on because she couldn't tell her husband her story. Now, she was not my patient initially. Her husband was my patient. He was the one who was sent to Vancouver, the VAST, the Association of Torture, because he had been tortured, and he was one of the most ill people that I have ever treated with post-traumatic stress disorder. So he had no idea what was going on with her. Some of her re-experiencing symptoms are reliving symptoms. Lots of nightmares, visual images. Flashbacks don't happen as often as you might think when we talk about PTSD, but those cued and uncued memories, the flashbacks are actually, I'm in it again, I'm there. It's not necessary that people actually have that experience of reliving it, but they can have those vivid memories, and they can come seemingly out of the blue. Triggers from television, movies, being touched by her husband. Intense guilt and shame, which is really part of the PTSD diagnosis, and certainly worsened by her husband, who, when she finally did tell him, and this was a couple of years after I knew both of them, he was just absolutely devastated and still quite ill. And I remember her telling me they were watching a movie together, and it was an Iranian movie, and it was about a woman who was having an affair or some kind of inappropriate behavior from his perspective. And he said, "You're that kind of woman." So he viewed her as actually being responsible for her own assault. So what are some factors that make your patients particularly susceptible to developing post-traumatic stress disorder? Well, we know just being a woman increases your risk 2 to 1, but also a personal and family psychiatric history, and that's generalizable to any psychiatric disorder, of course. Low socioeconomic status and educational level, that's a touchy one because that can also have an impact on the kind of work you do. For instance, if you look at individuals who join the military who have a low educational level are more likely to go into the infantry, for instance. So they would be more vulnerable to developing post-traumatic stress disorder just based on the kind of work that they do in the military. And previous trauma and child abuse and cultural factors. So which of these is the most important? Which is the greatest factor, greatest risk factor? In my mind, it would be previous trauma, and I'm going to speak a little bit about that as well. So I have a question for you. We all remember this. Can you develop post-traumatic stress disorder by being at home and watching this on television? How many people believe you can develop post-traumatic stress disorder by watching this on TV? Lots of people usually see that, and actually I didn't used to say this because now that the criteria has changed for DSM-5, they actually spell out you cannot develop this from watching something on TV. I would argue, however, that if your partner, someone you love, someone you really cared about was on the 104th floor of one of those buildings, you absolutely could experience or develop post-traumatic stress disorder. So now it's my little disclosure story. I'm going to tell you, brand new psychiatrist. I was working in Nova Scotia. It was a hospital, the Nova Scotia Hospital, which was one of those really old inpatient psychiatric hospitals, and I had to stay overnight. It's about 10:30 at night, and I get a phone call, and they say, we think we're going to get mass casualties. There's been a plane crash, and even though this is not that kind of hospital, we think we're going to have a lot of people, so I want you to be prepared for this. Of course, nobody came. So that was the crash of Swiss Air. 9/11, which was off the coast of Peggy's Cove. And so what happened was nobody survived, as you would imagine. When the plane crashed, lots of people who lived around there from Peggy's Cove and Bayswater, the fishermen got in their boats and went out and started picking up pieces of debris. And so did a lot of people who lived in the area go along the ocean and pick up things as well. So it was maybe 6 or 8 weeks after Swiss Air occurred, and a friend of mine who lived in Bayswater was over at my house, and he said to me, I'm having a hard time. I went and I helped and I picked things up, and I saw things that I just couldn't believe, and I picked up a shoe and there was a foot inside, and I can't seem to get over it. I'm living this all the time. And I said, but Derek, it's just body parts. I know, it's terrible, but what I learned, I knew nothing about post-traumatic stress disorder at this point. I was a brand new psychiatrist, and for me, I had just finished residency, I just finished, being in emergency departments. I had my own cadaver for a period of time, right? So I was exposed to all this stuff. Derek worked at a sporting store. He had never seen a dead body, let alone body parts. So what I learned from this was, trauma is subjective. We can think that something is not traumatic because it might not be traumatic to us, and arguably, had I been the person picking up stuff along the ocean, I think I probably would have been traumatized too. But I'm this sort of new grad thinking I know everything. It is truly traumatic, or truly subjective, what your traumatic experience is. So the kind of peri-traumatic risk factors, what increases the likelihood that if you're exposed to a trauma at the time of the trauma that you're going to develop post-traumatic stress disorder, does have something to do with the kind of trauma you're exposed to. You can see that while witnessing an event is the most likely thing to happen, it's also less likely to cause post-traumatic stress disorder than something like sexual assault, where you might be least likely to be exposed to that, but it has the greatest likelihood. So there is an inverse correlation to the likelihood of being exposed and the likelihood of developing post-traumatic stress disorder. So this is an old slide, but it could be just touching, not necessarily child abuse, but Yeah, it's an old slide. I'm making the general point because I couldn't find one was sort of better than that. So these to me are the big four peri-traumatic risk factors for developing post-traumatic stress disorder. How personal the trauma is, what personal meaning it has, whether it's protracted or ongoing, whether there's a violent aspect to it, a risk of harm or death, and whether it's sexual or degrading. So you can imagine all four of those fit very well into the category of childhood sexual abuse, where very often people know the person who's abusing them. It can go on over an extended period of time. It can be quite violent and certainly degrading and confusing. So that is why, from a sexual trauma perspective, it really has most of the peri-traumatic risk factors. Also, the presence of dissociation at the time of the trauma. And finally, the perceived helplessness or external nidus of control. I certainly experienced that a lot when I was working with the military, because at that time, most of our military work was as peacekeepers. And Romeo Dallaire around that time had the experience in Somalia. And one of the biggest challenges for him, and if you've heard him speak, he really is a very eloquent speaker. And the big thing was that he was forced to witness. So being a peacekeeper, you have a gun, you're trained on how to use a gun, and actually you're trained very well as a soldier, but as a peacekeeper you cannot act. You must be a witness, and that's what had happened for Romeo Dallaire, is that he witnessed people being killed. He had a group of people there that were trained to be able to intervene, and he was not allowed to intervene. So that external locus of control can be quite a powerful risk factor. What about post-trauma risk factors? The lack of social support is thought to be one of the greatest predictors of later life developing, or later on developing, post-traumatic stress disorder. And you can imagine someone's away in the military, they're serving somewhere, they have a horrible and traumatic experience, they come home and their partner has left them, their home is being foreclosed on, they're financially in ruin. The more trauma or more risk associated with lack of social support, that increases the likelihood of developing and sustaining post-traumatic symptoms. That presence of shame and guilt is a powerful perpetuator of trauma risk, as well as those ongoing life stressors, and that's pretty consistent with every psychiatric disorder. Lack of appropriate early treatment and access to service, and despite the fact that we are definitely in a developed nation, a lot of the people that I see have been sick for a very long time before they've actually been able to access services. And that includes in the military. When you think about it, in the military, they have access to service, they have operational stress clinics, but there is also a great deal of stigma in the military associated with coming forward and saying, I've had this traumatic experience. Actually, when I worked with the military, I was on a Veterans Affairs board. And I had the shocking experience of listening to some of the other people that sat on the board talk about what they thought of mental illness in general. And one fellow said, we used to call them, what did they call them? Low moral, LMF, that's what got on your file, low moral fiber. So people were viewed in a very negative manner for coming forward. The names of, even at the time when I was working with the military, MIR is the medical clinic on the base, and you would be called an MIR warrior. So it was hard to get people to come to the PTSD clinic, and actually it was a particular area. If you were there, people knew that that's why you were there. So that was a challenge. And recovery-related secondary stressors, it is stigma that a lot of people have to deal with, but also re-traumatization. So I want to talk a little bit about the neurobiology underlying this, and my view is that early life experience is a powerful predictor of later life psychopathology. PTSD is a cumulative illness. I don't know that I've ever met anyone who had one traumatic event that developed post-traumatic stress disorder, and I've had experience after experience of people that had phenomenal trauma that accumulated over time. Can't believe that they were as functional as they were, and then a seemingly minor event flipped them into post-traumatic stress disorder. And I think that's probably something that you will see see in your practice now, is I've had family practitioners say, you know, I had someone that I thought had kind of a minor accident or a minor situation, and they have what looks like full PTSD, and I don't know whether to believe it or not. And in my experience with the military, when I first learned about this, I would have these people that would have an event that I think most of us would think didn't seem like that big a deal, that huge situation that would lead to the kind of decompensation that I was experiencing. And to a person, when I look back in their personal history, they had lost their parents early on, they had experienced physical or sexual abuse, they experienced a major loss early in life. And I learned from that trauma and post-traumatic stress disorder is truly an illness of accumulation of trauma over time. So this chart, let me see if I can figure out how to press. There we go. Okay. What this is showing is basically this is us. We have genes. We come into life, 50% of our DNA from mom, 50% from dad. It's a big roulette. We don't know what genes we're going to get from them, but this is what makes us who we are. We have an endocrine and neurochemistry system that is unique to us, but all of this is impacted by our experiences early in life. I don't know if you've heard anything about epigenetics, but it's a really interesting area that is now more and more applicable to psychiatry. The way I learned about epigenetics actually early on was fairly recently. I was listening to Quirks and Quarks one Saturday while driving to soccer, and Bob McDonald had a guy on who was a geneticist, and he said, have you noticed that we have more and more individuals who are developing lung cancer with no risk factors? They're not smokers, they haven't been exposed to asbestos, but we have this uptick in the number of individuals who are developing lung cancer without that risk factor. Why is that happening? And he said, it's probably for a number of people related to epigenetics, meaning their grandfather smoked. That led to a change in the gene expression, whether turning on or turning off particular genes, that actually then became heritable, and that person had inherited that particular gene that through exposure to something turned on the risk for the lung cancer. Now we're seeing that in psychiatry, epigenetic phenomena, exposure to the environment can lead to later life psychopathology. So we're all born somewhere on this vulnerability, resiliency, teeter-totter. Some of us pop out of the womb and we're highly resilient individuals. We can really take a lot, and other people are truly very vulnerable. That has an impact on whether you're very vulnerable, the likelihood of developing PTSD when you're exposed to a trauma. Because sometimes when people are very resilient, they can be exposed to something that arguably is a massive trauma and soldier on. However, the more trauma you're exposed to over time, no matter how resilient you are, ultimately people can end up, despite the fact that they're highly resilient, developing post-traumatic stress disorder. We know trauma is ubiquitous. Probably half of the world's children will be exposed, unfortunately, to a really severe trauma or adversity. About 230 million children are living right now in areas affected by conflict, and probably more than that. That's 2014 data. So what do we see in our practices when we see young people who are living in poverty? So think of a mom who's living in poverty. She's pregnant, she's in a lot of distress, maybe her rent can't be paid, she's not getting enough food, she's pregnant, she has a baby. This impacts on her environment at home, her level of stress. The child is born, goes to school, and has these adaptation behavioral difficulties. Well, what can be going on behind the scenes neurobiologically is that chronic stress that the mom in utero and postpartum experiences can impact hormones and neurotransmitters that ultimately leads to those behavioral and emotional consequences. And a lot of the research here has been done with rats. And I don't know if you've worked with rats before, but rat dads are apparently kind of deadbeat dads, but rat moms can be very loving and nurturing. And there's two kinds of rat mums. There are high lickers and low lickers. The high licking rats, very nurturing, lots of licking and grooming, and the low licking rats, this truly runs true in families. So if you are a babe of a high lick mom, you will be a high lick mom yourself. If you're a babe of a low lick mom, you will not lick as much. This is a stable trait. The environment The stress that you're under predicts, however, the level of licking. So if you're a high lick mom, but you're in an impoverished environment, a stressful environment, that will mean that you will lick less. I'm coming to a point here. It's all about the licking. Tactile stimulation, that licking, promotes growth. It has an impact on growth hormone and cortisol levels. So it not only increases growth hormone, but it also suppresses those catabolic glucocorticoids that inhibit growth. And if you look at the data, it's stunning. That licking impacts every aspect of that new pup. Its stress responses, its immunity, neural development, learning, memory, metabolic, the number of pups it has, how big the pups are, how long their tails are, in some cases, the color of the pup. So it impacts every aspect of that pup. Why? Well, there's a true hormone connection here in that the gene for the glucocorticoid receptor is stably influenced by maternal care. So if you are a high licker, you are going to, in your pup, create a lot more glucocorticoid receptors. If you have lots of glucocorticoid receptors, it means that you can keep very tight control over the amount of cortisol. If you're a low lick mom, your pups are going to have fewer glucocorticoid receptors. When you have a stress response, you're going to have an explosion of cortisol, and that has toxic impact. The good news is that those low lick babes can be adopted out to high lick moms and actually have normalized glucocorticoid levels. The challenge is, how long do they have to be exposed? How much stress is enough stress that it's not reversible? That's the big challenge. So they create different kinds of models, and a more human model, most human babies aren't, the mom isn't completely removed, or the caregiver isn't completely removed. So they do things like they don't remove the mom, but they remove nesting material. So there's not enough to create a safe and comfortable nest. So the mom's maternal behavior becomes less predictable, more fragmented. She spends less time. And that period of deprivation actually leads to anhedonic pups. So that stressed mom, then the pups don't enjoy usual rat pup activities. They're not getting the usual pleasure out of life. Now, what they thought was that could lead to cognitive consequences. And certainly in middle-aged and older rats, the ones that were exposed to that stressed out mom had cognitive impact. What they didn't see was cognitive impact in the adolescent rats until they did it under stress, until they had to do cognitive tests under stress. And when they stressed, those young rats who were exposed to their maternal stress, they already had cognitive impairment associated with the amount of stress that their mom was experiencing. So that, I heard this woman speak last year, and really a brilliant woman, and she said again and again and again, unpredictability and fragmentation of maternal care has enduring impact. And I truly believe that not having a loving, non-chaotic environment has a massive increased likelihood of leading to later life psychopathology, not just PTSD, depression, anxiety. We know that our brain changes from in utero until we're about mid-20s. There's a lot of pruning that goes on during that time. And we know that the perinatal period, just before you're born and just after you're born, you are highly vulnerable to the environment, and the impact of stress can be potentially permanent. The problem is, as I mentioned, we don't know what kind of stress has to happen. How severe does it have to be? How long does it have to go on? Does anyone have a teenager? Right? Does their brain work? Do they have a functional prefrontal cortex? So your prefrontal cortex, that's your executive of your brain. Organizing, planning, forward thinking, critical thinking. If I'm late picking up my daughter, it's kind of rainy and wet and slippery, and I'm kind of going faster than normal, and the light turns yellow, but I know I'm really late, and so I'm deciding, am I going to go through that light? Maybe there's a police officer there. That's all prefrontal cortex. Does a teenager's prefrontal cortex work? No. Until they're about 25, your prefrontal cortex is not fully formed. This paper that was in Scientific America, brilliant, and if you want it, you can email me and I'll send it to you, gives you an infinite amount of patience with your teenager when you realize their brain simply does not work that way. So not only is there ongoing pruning, particularly in that prefrontal area during their teenage years, but it's also a time of very important neuronal connections. That's why most mental illness starts in the teenage years. And I think it was in this paper, another paper I wrote, he said it so well, there's so many moving parts, there's a lot of opportunity for things to go wrong. So during those teen years, your brain isn't working properly, there's a lot of connectiveness going on there, and about 85% of psychiatric disorders start at that time. So when is it that you shouldn't be exposed to trauma? Anytime during childhood. Probably in the perinatal and those early years is most important, but anytime until your teen years and then onward from there. So not all stress is bad. That's usually a point that comes out, well, isn't it good to be exposed sometime? Well, absolutely. It's good to remember what's dangerous. So it's not necessarily a bad thing to have stress. It's the long-lasting or intense stress that can result in those detrimental effects. So I want to quickly show you a little bit of data, which I think is really quite powerful. This is childhood adversity, and this is 12-month risk of developing depression, and on the lower line, the number of past year major stressful events. So this is just in the last year, what's the likelihood that you're going to develop depression? The first line here, these guys have had no childhood adverse events. So childhood adverse events would be like a divorce, loss of someone who was really important. I think they're down at the bottom there. Neglect, abuse, they didn't have any. If you had no stressful event over the last year, the likelihood of getting depressed is very low. If you have a couple of stressful events, it increases the likelihood. And of course, if you've had a horrible year with tons of stressors, you have a greater likelihood of developing depression, but it's still quite low. The next line, these guys have had 1 or 2 child adverse events. And you can see that just out of the gate, even if you had a great year, you've got about twice the likelihood of developing depression. But the more stress you're exposed to, you have a massive increase in the likelihood of developing depression. Now, this is in almost 35,000 adults, so this is really, really robust data. And to show you the next line, 3 or more childhood adverse events right out of the gate, you're about 5 times more likely. There's a massive increase, in the likelihood of developing psychopathology related to the number of childhood adverse events. The next data I'm going to show you is really showing you some of the very same things. This is a 32-year prospective study. And the same thing, the blue lines are no childhood adverse events, the yellow are 1, and the red are 2 or more childhood adverse events. I've just told you your risk of developing depression increases, and you can see that because these lines aren't overlapping, this is statistically significant. The more trauma you're exposed to, increased major depression, but also increase of inflammatory markers. And I don't have time to go into it, but I believe depression and anxiety are inflammatory illnesses, and this is just one marker of C-reactive protein and showing the impact of the number of traumatic events in changing your inflammatory markers. Also clustering of metabolic risk factors. So we know being depressed, being anxious, having schizophrenia, having bipolar increases your likelihood of developing metabolic disorders anyway, and there's a correlation with trauma as well. Any disease risk. The mind-body connection is real, and you can see the massive increase in exposure to childhood events and developing any kind of illness. So what are my questions that I ask? And I think anytime you're doing a psychiatric assessment, anytime you're talking to someone that you have a concern, the first question is the one you got to ask, which is, have you experienced during any time in your life any kind of abuse, physical, sexual, emotional? And usually I'll ask, is there something that's happened that you feel like you just can't get over? Do you feel like you're reliving events? Those are you can go through the criteria, but those first 2 are really the most important. Have you experienced abuse? And sometimes people won't tell you, but at least it's out there that you're open to hearing about it if they decide that they're going to tell you. And is there something that's happened that you can't get over? The next 3 are really just around the criteria. Do you feel like you've relived events? Do you tend to avoid situations that remind you? Are you jumpy, irritable? Is your sleep poor? So those are really, once you've decided you're going after a diagnosis. But those first 2, they're really valuable in any kind of psychiatric assessment. I'm just going to talk quickly. How much time do I have left? I'm not getting any message.
We've still got 6 minutes.
6 minutes, okay. Very quickly about pharmacotherapy of PTSD. We have a number of trials showing the value of medication in post-traumatic stress disorder, but this is quite controversial. So I think if you view all psychiatric illnesses as biopsychosocial and you recognize that the psychological aspect is very powerful, important, psychotherapy can have an impact on gene product, can cause epigenetic changes, so it is an important aspect of all mental health treatment. In post-traumatic stress disorder, medication is a useful tool, and there is some good data, particularly for SSRIs. So SSRIs, SNRIs probably have the most data in post-traumatic, they do have the most data in post-traumatic stress disorder, and particularly because most people who have severe post-traumatic stress disorder are also going to present with depression. They often have substance abuse as well. They may have other anxiety disorders, but it's very common to have both the post-traumatic stress disorder and ultimately the depression. We have a number of maintenance trials as well. So these are the anxiety guidelines from just a couple of years ago for post-traumatic stress disorder. These are Canadian guidelines, and really what you need to know is try SSRIs, try SNRIs. If someone has really significant anxiety symptoms, those are the most likely to be valuable in this population if you're attempting pharmacotherapy. Like any anxiety disorder, generally you actually require higher doses and longer periods of time. Anxiety is harder to treat than depression, but you must always do the start low, go slow approach to any anxiety disorder. So start at the lowest possible dose, increase slowly, but aim for full symptom benefit. It may take, if you think about depression, something should be happening in 2 weeks, and you should really be getting good symptom control in 4, 6, 8 weeks. With post-traumatic stress disorder, with any anxiety disorder, thinking out 8 weeks, 12 weeks. It takes longer and higher doses are often required. There is some good data, and this is in the sort of adjunctive therapy here. I don't know if any of you are using atypicals in combination for your depressed patients, but there is also some good data in using atypicals in combination, whether that is quetiapine, Seroquel, aripiprazole, Abilify. So there is a role for those medications in this situation as well, but starting off certainly with an SSRI or an SNRI, optimizing that. If you're not getting anything out of the first one, cross over, try another one, optimize that, and but combinations certainly have some value as well. I'm happy, now, oh sorry, I'll just mention, it says not recommended. I'm happy to talk to you about benzodiazepines at the end and give you my opinion on this, but there is a role for benzodiazepines in many anxiety disorders. Their role is as a blanket, as a Band-Aid in the short term while we're trying to fix things from the inside. I swear to you that most of my patients stop their clonazepam before I ask them to. The people that get into trouble with benzodiazepines are really mostly it's related to poor prescribing and not to the patient and their experience with benzos being really dangerous as far as addiction. I know not all of you will agree, but I was a pharmacist. I spent a whole year doing a benzodiazepine course, and I believe that they're compassionate and appropriate medications. Just very quickly, I was just actually at the 9/11 memorial last week, and if you ever have a chance to go, it's actually an incredible museum and incredible memorial. And I took my son with me, and he was absolutely blown away as well. But I was so surprised at how vividly I remembered so much of that experience. And I didn't add those slides about 9/11. I have had those in my talk for some time. But having just been there, it sort of reminded me of exactly where I was and all the experience from that time. But we know that cognitive behavioral therapy has the most empirical evidence in post-traumatic stress disorder, and it's difficult to get cognitive behavioral therapy that's high quality, have access to it, be able to afford it, but we certainly know that the data supports CBT, both from a cognitive and a behavioral approach. And I'm going to give you these slides, so you're welcome to have a look through. There is I will say that when I first learned about post-traumatic stress disorder, I worked with some awesome psychologists in the military, and they'd been up and running for about a year. And when I arrived, everybody was so sick. There was no other psychiatrist there, but there were awesome psychologists, and they knew what they were doing. Everyone was so sick. No one was getting better. Why were they not getting better? Because you can be too ill to do psychotherapy. If you can't remember, If you can't focus when you're reading an article, you get to the end of it and you can't remember what was at the beginning, it's very difficult to learn, and cognitive behavioral therapy is about new learning. Every interaction you have with a patient is psychotherapy. Every interaction is valuable, the empathy, the experience, and working with good therapists, you can create an environment of safety, but sometimes they need medication. And so exposure therapy has a great deal of data, prolonged exposure, but also not indiscriminately. So I've had some patients that had horrific trauma, felt that it was well contained, that they had dealt with it, and it was in a place in their life where they managed it, had exposure to something else and got quite distressed, and a caring nurturer came in and took the top off the can, and out came all the old trauma, and the person was completely incapacitated. So you don't always have to go through the trauma. If you have it contained, if you're functioning well, maybe you've managed it. You're resilient and you have the skills to be able to manage it, and you have to be very careful about referrals that people do not indiscriminately do trauma therapy. I'm going to move past this because I know I'm just about out. The last thing I want to mention is about, the last thing I want to talk about is acute trauma therapy. So this is situations where a large number of people have been exposed to a traumatic event and they have critical stress debriefing. What is the data for that? And that was really, it was a sexy topic. Everyone was doing critical stress debriefing. Every large company had a critical stress debriefing program. Is that safe? Is that appropriate? The data is overwhelming that doing critical stress debriefing causes post-traumatic stress disorder. And so you should not be doing critical stress debriefing in the way that they were doing it. This is from a Cochrane review of 2009, favors control. So you can see down here, the data is unequivocal that critical stress debriefing is dangerous and provokes post-traumatic stress disorder. There's no evidence that a single session of debriefing is useful in preventing post-traumatic stress disorder, and compulsory debriefing should not occur. More appropriate would be a screen and treat model. Essentially, the recommendations are, if you are exposed to a traumatic event and it's part of a corporation or a group, you should be told, we are here for you. But you need to use the resources. I mentioned to you that having good family support, emotional support is one of the greatest protectors of post-traumatic stress disorder. The reason that indiscriminate debriefing seems to be dangerous is because it does potentially interfere with normal avoidance. It's part of processing a traumatic event, is getting yourself out of it. It may act as a form of re-exposure before you're ready to be re-exposed to that event. It may lead victims to bypass their usual support systems. I have this caring nurturer who I can go to rather than being surrounded by my family. People don't distract, and that's one of the greatest protectors of post-traumatic stress disorder as well. Because in your hyperadrenergic state, when you have just been traumatized and you got norepinephrine going crazy in your brain, that is when you lay down those trauma memories. And so they've done studies, there's some really elegant work out of Israel, where Israeli military were given propranolol when they were out in dangerous situations, and their risk of developing post-traumatic stress disorder is exceedingly low because their level of norepinephrine is very low. Now, I don't know if I want to be in a stressful situation without having norepinephrine, but one of the situations where I've seen, I think, is really a big problem is if someone is sexually assaulted. If you're sexually assaulted and you go to the emergency department, what happens? You're asked over and over again, what happened? What did it look like? What did the situation, what did it smell like? What was this? Every detail over and over again in a hyperadrenergic state. So while we're trying to protect the individual by getting rid of the perpetrator and getting that person out of the general public, we may actually be provoking trauma outcome in that individual. So just a couple of my PTSD pearls. PTSD is an abnormal response to a traumatic event. The most likely thing to happen after a trauma is to be acutely distressed and recover, and PTSD is only one aspect of the outcomes of exposure to traumatic event. Most people have multiple previous and multiple trauma before they develop a full post-traumatic stress disorder. personal, protracted, violent, sexual trauma is the most likely to lead to post-traumatic stress disorder. Trauma is subjective. What is traumatic to me may not be traumatic to someone else. And that was a life-changing experience to recognize that what I see as distressing is very different than what other people see. And it really does change the way you look at patients in your practice. That's it. Thank you. Does anyone have any questions?
Where does the concept of bullying fit into this?
It's a good question. I think there's, the question was, where does the concept of bullying fit into this? And I think that bullying can really set people up early in life. It can be some of that pre-trauma risk, that if you've had a lot of bullying, you've really struggled in your early years with fitting in, it can be sort of an early traumatic event that may not be enough for some people to flip them into a full pathological state, but might prime them for later life traumatic events, flipping them into post-traumatic stress disorder or depression. I don't know of, I haven't had patients that have developed PTSD, I think, strictly around having been bullied, but I think that bullying can have a profound effect for people, particularly later in life when they're already creating that vulnerability.
Do you have an estimate of the co-occurrence of addiction with PTSD? If you look at a population of people with addiction, what percentage?
I don't know the risk in that direction. I know probably about 30% of people, and that might, in my population, it was very high, who had PTSD, who had addiction, but when you look overall, I think it's in the 25 to 30% range. But I don't know in the addiction population. Does anyone else, anyone know?
I work in the detox setting, and I would estimate that 80%, maybe more, so it's so prevalent. And the question is, we often avoid in that setting, we avoid talking, encouraging people to talk about their trauma. At what point in treatment of addiction do you think that sort of thing would be appropriate?
I agree that in an unsafe situation, when you haven't created that therapeutic alliance, that starting to talk about trauma can be very destabilizing. So I think letting someone know that this is a safe place and that when you're ready, you can talk about it. But if you feel personally, I don't think they're ready to do it, rather than you're not stifling them and saying, I don't want to hear it, but say, I want you to talk about this when it's a really safe environment for you, because I have certainly had many patients that have gone through rehab and overshared in that environment and been very destabilized. And I think people sometimes feel when you're going through an addiction process that that's part of breaking someone down, but I think you actually open a brain up to further trauma and re-traumatization in that situation. So I think you have to be very cautious in that process.
I actually have two questions, but I'll just use one. POT, where does POT fit in all of this? Because we're about to be subjected to that.
Okay, so I got to tell you, I have very strong POT feelings, so you'll have to take it in the context of, I think POT is a horrible drug. And the reason I think it's a horrible drug is because I think we have an abundance of evidence about its risk in vulnerable brains for epigenetic phenomena, for turning on or turning off genes, turning on genes for schizophrenia, for bipolar, or turning off protective genes. And I think we have an abundance of data showing that if you have a vulnerable brain, pot is a bad drug. And we all probably have patients who are older who say, I used to smoke pot, but now I can't because it makes me paranoid. This is because marijuana has been bred so that all the antipsychotic part of it is gone, and it is a pro-psychotic drug. When you do an MMPI, a personality assessment on PTSD patients, and when I was with the military, the psychologist did this slew of tests. They look all the world on those personality inventories like they have schizophrenia. They can have micropsychotic episodes, they can be highly paranoid, and I think that pot is a bad drug in that situation. I think that as medical professionals, we have done a terrible job in promoting the side of pot as a danger, particularly in a developing brain, and that's up to about 25. And when I moved from from Nova Scotia to British Columbia, like, people do this as a family thing. It's like they treat it like oregano. It's everyone can smoke pot and it's safe. And you know, I would actually, if you tell a kid you can't have sex, you can't drink, you can't smoke pot, blah blah blah, they're going to do all of it. So I would rather kids learned how to safely drink alcohol than I would to smoke pot, because I think its danger in a developing brain is so significant. But I welcome another opinion if someone disagrees, because I have strong opinions in that area, and I'm certainly not asking anyone to go and drink. But if I'm picking the two, I really worry about pot. You, and then I'll ask.
So I work primarily in an addiction capacity as well, like Bill. And just on that subject, sort of from medical training and from obviously the literature and stuff, the effects of marijuana, there are many negative effects, but clinically I have so many patients who say that it really is helpful for their anxiety. And I know there isn't literature that supports that, but how do you, and I've sort of pushed many people to get off of it, right? And they have done worse.
So I hear you. I have a lot of patients that feel that's the only way I get to sleep. It's the only thing that manages my anxiety. And what I work toward, I'm a pharmacologist, so what I try to do is replace it with something that I hope is safer, because they also can have some significant side effects. There's some argument about pain relief, and some of my patients will say that is the only thing that gives me pain relief. My biggest concern in that is the young brain, under 25. You want to smoke pot when you're 28, knock yourself out. But in that young brain, and who knows if you're a vulnerable brain, that's the problem. If you have bipolar in your family, you got a vulnerable brain, but a lot of people, we didn't use the word bipolar, right? You're looking for a family history suggestive of bipolar, that, there's a lot of substance abuse or chaos in the background, or granny was in Riverview, or someone, a lot of suicide. You're not going to hear the family history of bipolar necessarily. More often you'll hear the schizophrenia story, but in those younger brains, that's where I have the greatest concern. Otherwise, I'm trying to give them something, replace it by fixing it with an antidepressant and that kind of thing.
So in sort of older individuals, 30 and older,
I have less of a problem with it. Yeah.
I'm just curious about the critical incidents stress debriefing that you talked about there. Mostly worked in rural Aboriginal communities and been part of critical incidents response to a number of different situations. And so I totally hear what you're saying. You're very clear about the evidence, but is it the indiscriminate issue in terms of providing that care, or can you just clarify that?
Absolutely, and I indiscriminate, absolutely, but also a lot of those critical stress debriefing, and that includes in the police departments, in many different situations, people were being pushed to talk about the trauma. And I think where the evidence really is to create a safe environment. If you're part of a First Nations community, then maybe doing some cultural comfort activities. But the pushing people to talk about trauma in a hyperadrenergic state causes PTSD, and that's the really troubling part. So when I'm involved with someone who's had an acute trauma, what I do is urge them, first of all, to distract themselves as much as possible, surround themselves with people that love them, try to get normal activities, sleep and eating well and all those sort of self-care things, but not to spend time on the trauma, because the more you're talking about it when your brain is so activated, that has the evidence for creating traumatic illness. Okay?
Thanks.
My pleasure.
And social factors like how...
Can you start at the beginning? I missed the first
So
part.
I was just looking at different angles, personal, genetics, and protective risk, support systems. So I'm giving you just personal story, from 1984 I was in my grade 10.
You were?
I was in my grade 10.
Yes.
So the story goes around like there was some like a divisive society back in Punjab, like that's where I'm from. So there was lots of terrorism, lots of discrimination, minority versus majority, political situation, and then like even in the medical college we were isolated, like just like this group of students should move out of this college, you can't stay in the hostels. So main thing was like how the social system, how your family supports you, how your faith group supports you, and what's the motive of your journey. So that kept us focused, like even though we were in minority system, like there were bus service, like we can't go home after 4 o'clock in the evening. So that's what the last bus we can go. So how people survive like without food, like sometimes. So those are the factors, like how, what is the motive, what is your defense system, how you make resilience. It's not just like the exposure, like from 84 to 92, like that was 8 years in a row. So that's where like the peace was established in Punjab, like from 1984 to 1992. So how people survived, how much they took it out. And I see like only thing I can see from my class, our batch of students, like maybe 40% they are outside India. But their main focus was we want to study and we want to prove nobody can stop us.
You tell a great story of exactly what I hope I've made the point of here, that the power of social support, of having a group experience, everyone is supporting each other, hopefully loving families. I mean, you know, my patients are all terrified if I have children, I'm going to cause the same problem in them. But if you love your children and create a non-chaotic environment, that is so powerfully protective. So that social support, I believe, is one of the greatest protectors. And you're obviously a resilient individual. Hopefully you were born with some of that resiliency, and it was reinforced by the people around you who cared about you and wanted you to be successful. All right. Well, thank you very much for your attention, everyone. Thank you.